I'm just going to go through the normal drill and the protocol. We may not have a whole lot of bill introductions in here, but I'll do a request for bill introductions first, get that out of the way. Do not have it. Okay, so today this may be a fairly short meeting. I want to go through staff introductions first. And who do we have that's working WebEx? Because I don't have. Okay, and you are? Okay, so we've got Anthony, the AV Tech. Okay, so can we go around the table starting with Dayton?
Good afternoon, Chairperson, members of the committee. My name is Dayton Lemunion, Senior Fiscal Analyst with Research. I'll be serving as the facilitator, so your KLRD contact for the committee. If you have any questions, reach out to me and I'll be happy to help and direct you where you need to go. I also handle the budgets for the Department for Aging and Disability Services and the state hospitals.
You want to introduce those, please?
Hello, I am Amanda Prosser. I'm from Kansas Legislative Research Department as well. I will be presenting the budgets on Department for Children and Families, as well as Healthcare Stabilization Fund, Office of the Child Advocate, and I think there might be one more in here. Mortuary Arts, Board of Mortuary Arts is in here as well.
Okay.
Mm-hmm.
Hello, Julia Kofoid, also with Legislative Research, and I have Kansas Guardianship Program, which will be presented in front of you.
Thank you.
There are a couple more. They're not able to make it today. Molly Pratt will be presenting the budget for veterans, and Megan Leopold will be here a little later. She's presenting in another committee, and she'll handle KDHE Health.
Thank you. And we have, is Jenna?
Good afternoon, committee. My name is Jenna Moyer. I'm with the Revisor Statutes Office, and I'm usually also in here. You'll have Jill Walters, who's also does more of the heavy lifting on the appropriations side, but I'm more the subject matter person.
All right, Jenna, thank you. Please, Francie.
Okay, my name's Francie Hernandez, and I will be the committee assistant, and this is my 5th year with social services budget and about my 12th year here at the legislature.
Thanks, Francie. Okay, so now what I'd like to do, typical for any committee on their first hearing, is just to go around the room and have the representatives introduce themselves and their district, and then we'll get into the overview of the interim reports. If we can start with Representative Wilcott.
My name is Sean Wilcott, and I'm representative of District 62, which is Nemaha, Brown, and Northern Jackson counties.
Okay, thank you.
Representative King, Mike King from Heston. We have Harvey, McPherson, and Marion counties.
Thank you.
House Representative Melissa Orpeza, District 37, Wyandotte County.
Thank you. I'm going to skip myself and go to Carpenter.
Will Carpenter, District 75, Northern Butler County.
And I'm Barbara Ballard, 44th District, Douglas County, Lawrence.
Thank you.
Alan Rivas, District 63, Donovan and Atchison County up in the Northeast.
Thank you.
And Representative Angela Steens from House District 39. That's Shawnee and Lake Quivira in Johnson County.
Thank you. Can we get Representative Ruiz on?
Good afternoon, Representative Susan Ruiz, and I represent District 23, which is Shawnee, Lenexa, and Dolan Park.
Thank you. Okay, I am Representative Dave Beeler. I'm from the 40th District, which is mid to southern Leavenworth County, city of Lansing, part of city of Leavenworth, and then out to the Missouri River. So I'm glad to be here. This is my first rodeo as a chairman, so please don't hold that against me. I know there's a lot of experience in this room. There's a lot of faces that I recognize from the last few years on Health and Human Services, and I'm looking forward to this opportunity. So with that, what I would like to do is turn it over to Dayton, and we go through some of our overview of interim reports.
Thank you, Mr. Chair, members of the committee. I'll be reviewing 3 interim committee reports that met over this past interim. So the first one that you should have on your packet or online is the report of the Special Committee on Targeted Case Management. So targeted case management, as a background, is a Medicaid state plan service that assists individuals with intellectual and developmental disabilities with coordinating their services. And if you turn to page 3, you'll see the recommendations. The genesis of the committee is that KDAD's indicated that CMS requires that targeted case management providers be separated from those who provide the waiver services. So KDAD's provided testimony stating that fact, and the targeted committee, or the special committee, made recommendations following public testimony about that topic. The Special Committee on Targeted Case Management recommends that KDADs distribute a survey to individuals on the waiver, individuals on the wait list, and to other stakeholders. Findings should be reported to members by December 15, 2024, and the survey should ask 3 questions. Are you satisfied with the services received from your community developmental disability organization and targeted case management provider? Are you aware that you can change TCM provider? And what feedback, if any, would you give to KDADs regarding your services? The next recommendation, KDAD should develop a Kansas-specific response to meet requirements by the Federal Centers for Medicare and Medicaid Services to prevent conflict of interest in providing TCM, including allowing agency-based and independent case managers indefinitely, allowing all available flexibilities, including a clear firewall for agency-based providers, and building a robust monitoring system, including allowing exemptions in rural areas. The next recommendation, the House and Senate Health Standing Committee should review TCM provider capacity and TCM reimbursement rates. And finally, the committee also approved writing a letter to CMS requesting written documentation of the conflict of interest violations and guidance from CMS regarding the need to separate case management providers and service providers, as well as whether CMS is aware of any rules put in place in Kansas. So those are the recommendations. Kind of a lot to throw at you on the first day, but happy to stand for questions.
So committee, any questions on this particular report? Representative Carpenter.
Thank you, Mr. Chairman. So maybe to put Michelle on the spot, we did get the letter, right? Okay. So we in the meantime, when we asked for that letter, they responded, what, last week? I think it was last week. So we do have the letter, so there is now no need. The revisers were drafting the letter, and it's very complicated to send a letter from a committee to the federal government. But anyway, in the meantime, they must have just heard us, because they sent a letter that explains everything the committee wanted. So I just wanted to add to that.
So we got the response. My question would be the second 2 bullet points of this committee, where it was on the targeted case management and the conflict of interest, and actually, why are we doing this? So do we feel we have that clear direction in that response? I guess that's what I'm asking. Because as I go back, and if you'd like to approach the mic or the well.
I was going to say, I should have noted the agency folks are available for questions, so thank you to them.
Yeah, so for the rest of the committee, the interim committee met back in, I think it was October-ish, and there was a lot of people on the IDD list who had concerns about the targeted case management and some of the guidelines that were coming from CMS. And so I'm a little bit shocked that we actually got a response. So I just want to make sure that it's clear in what we were asking for. So, and if you would introduce yourself, and we'll go from there. Thank you.
Hi, I'm Michelle Hayden. I'm the LTSS Commissioner for KDADS. I oversee the 7 HCBS waiver programs. This conflict of interest rose out of the federal regulation from the settings final rule to make sure that we have integrated settings and conflict-free services for people with disabilities. And in the IDD world, as it's grown in Kansas, oftentimes TCM was also connected with community service providers. And with the rules with CMS is that you cannot serve someone that is also receiving services from the services part of that. So for instance, in Douglas County, we have Cottonwood, who provides a number of services, but they also provide case management. And that's considered a conflict of interest because they're also the CDDO, which they're supposed to provide conflict-free information to people that are seeking services. Now, actual or perceived, that's what it is, that they could be perceived as being conflicted information when they go to Cottonwood, even though Cottonwood may give other choices for people to get their services from other providers within Douglas County.
Thank you for the explanation. I don't think that answer is going to make a lot of those people who are using those services happy. And I'm not shooting the messenger by any means.
I know.
But that will not resonate well with those people. So thank you for the explanation.
You bet.
Yep. Representative Carpenter.
Mr. Chairman, thank you. So with that, we serve 9,400 people in the roughly 9,400. I'm not going to be exact, but I'm just kind of, and so roughly 1,200 of those folks are served by outside the provider services. So they are conflict free. That leaves another 7,000 or 8,000 people that are in this federal requirement of perceived conflict. And how we build literally a system of targeted case management folks to serve arguably 8,000 people that are now receiving their targeted case management from a provider is a large task, to say the least. And that's what we're faced with this letter, which was pretty to the point, as far as I'm concerned, about what happens if we don't do it. And federal funds could be at risk. I mean, they have a pretty good sized stick when it comes to federal money. So all I can say is stay tuned.
So no more. So Michelle, could you shoot me no need to approach the well. If you have a copy of that letter, or Representative Carpenter, can you email it to me, please? Sorry about that. Okay. Representative Ballard, do you have a question?
No, I don't have a question. I would make a comment that even though, I think people see it, and with the letter, it's a perceived conflict, it puts people that are actually there and actually in Douglas County and Jefferson County and different places that use the facility. Then if you change that, how does it affect those individuals? And I don't think the letter really addresses how it affects the other people when you change this, and they may have been this way for 15, 16 years, along those lines. And what you do know with people with developmental disabilities, they need the continuity, and they need to count on what's really happening. So on one hand, it could be a conflict of interest perceived, but not really. But then what happens to these individuals that have been used to this setting and what they've been doing and effectively doing it and maybe working within stores and restaurants and everything else? How does all of this affect them and their developmental disabilities?
Thank you for that. Representative Ruiz, did you have a question or comment?
I actually have two questions. One is, definitely confirms that we that a person receiving services through receiving the target case management and through a community service provider, that those providers are the same providers. That does that letter totally confirm that it has to be two different people?
I'm seeing Michelle shake her head up and down, yes.
Okay,
And
so my second question is, can this committee make a recommendation that could say something like that everyone receiving those services right now stay the same? So in other words, they get grandfathered in, and anybody new coming into services, that they would have to have the two separate services so that it's a very clear distinction between the two.
I'm seeing head shake no on that question. I don't know if there's a way to research that or to get further clarification. We can take a look at that, Representative, just to see. The initial indication is no.
And the no came from where? Sorry, because I can't see.
I'm sorry, it came from Michelle.
Okay. All right. Yeah, I think we need to research that. There is such a groundswell of people that are receiving all those services, and the upheaval is going to cause them. It's counterproductive, and it does not provide them choice, which is one of the main staples of providing IDD services, that the person have a choice, and this is taking that choice away from them. And I think it's worth us researching whether folks could be grandfathered in, and all new people will have to have the distinctive two services or providers.
Michelle is smiling in the audience, and she has agreed to take that for action. So thank you.
Thank you.
Any other questions on this particular interim report? Okay. And Dayton is sending the letter to the rest of the committee members. Thank you. Okay. The next interim committee report, are we ready for that? Okay. Okay.
Good afternoon.
Good afternoon.
I'm Megan Leopold with KLRD. I missed staff introductions, but I do have several budgets in this committee. I have the budget for KDHE Health, the Board of Nursing, and the Board of Pharmacy, which will all be heard by this committee. And I am going to provide information on the interim committee reports for the Bob Bethel Joint Committee on Home and Community-Based Services, as well as sedation dentistry. So I'll start with Bethel, if that's all right. The Bethel Committee meets quarterly. Their recommendations for fiscal year for this past interim were for the Department of Health and Environment to implement a GME program, Graduate Medical Education Program, at the Kansas Behavioral Health Center for Excellence. They had a recommendation that a budget proviso be drafted to address 3 pending issues with the CHIP program. The first being that the current eligibility limit is set to be 250% of the 2008 poverty level. And this would change it, as budget provisos have in the past, to be 250% of the current federal poverty level. There's also a recommendation to address the wait list and the lockout periods. The committee recommends that the Social Service Budget Committee review providing grant funding for local communities to provide a resource guide. There's a resource guide that had been provided previously that is now out of print. They have recommended that a budget proviso be drafted for additional substance use disorder state funding through a grant fund to supplement federal funding for those SUD providers that go through their allocated funds. And then there is a recommendation to adopt COMFRE rules for the committee. And then finally, a recommendation to continue to rebase the PACE rates through an annual budget proviso. Do you want me to go over the proposed legislation, or should I move on to the next report?
Give me 1 second, please. Committee, is there interest in hearing the proposed legislation? I'm not seeing energetic hands, so if you want to move on.
Okay. The next one is the Special Committee on Sedation Dentistry. The committee reviewed the scope of practice of certified registered nurse anesthetists. They recommend that that be reviewed and that they review the authority to procure their own medication under the USDE. They also recommend that the overall rate increase for dental providers allow for the reimbursement of partial services. The sedation, I should back up a bit. The Sedation Dentistry Committee looked at sedation dentistry services, which are services that are by and large provided for very young children or those in the IDD population that need to have some sort of sedation or behavioral management during their dental procedures. And there has been a shortage of this type of service has been discussed during committee meetings in the past, and so this committee was looking at ways that that could be addressed. So the rate increase for dental providers that allows for the reimbursement of partial services, that is many times when individuals are receiving these services, they're not able to be completed because of behaviors or something that comes up medically. These are also very high need medical individuals. And in those circumstances, dentists are not being paid for any of the service. So this recommendation is looking for that to be changed. They also have recommended that KDHE share with the committee the sedation dentistry report totals using the current Missouri rates, as well as rates that are 80% of the usual and customary rate. So this is looking at what a rate increase would look like. They are also recommending that KDHE provide a fiscal note to raise the cost of the dental code G0330. This is a facility fee cost for using an operating room or an ambulatory services room. And they're recommending that that be raised to the Medicare rate, which is just above $3,000. The committee has recommended that a complete and accurate list of dental providers and anesthesiologists be provided to families. This would allow them to easily see who had available services for sedation dentistry and who is taking on new clients. They also recommend consumer education around the connection, the importance of taking care of your teeth, and the connection between dental care and overall long-term health. They recommended exploring dental incentives with the intention of recruiting and retaining more dentists in the state. And then finally, they supported the My Dental Care Passport, which is a passport that individuals can carry with them that helps providers understand the special needs that they may have and how that provider can support them in that process. And those are the recommendations.
Committee, any questions? Representative Ballard.
Thank you, Mr. Chairman. Is My Dental Care Passport something new?
I don't believe it's new.
Or was it under another title?
I don't know if it's under another title. I don't think that it's used very regularly, and so they're looking to support that. And I can get you more information on that, and one of the agencies also might have more information on that.
Thank you.
Committee, any other questions? Representative Orpeza.
Thank you. So my question is on the bullet point number 2, including allowing for reimbursement of partial services that do not result in a dental service being provided. Is that because of behavioral issues or lack in screening and they need to have sedation?
It's generally a patient that has been referred for sedation dentistry work. but during the course of that, either their medical needs or their behaviors force the procedure to be stopped. And so it started, but then for whatever reason, the dentist can't continue safely with that procedure, and so they have to stop the procedure for that patient.
I have an additional, oh, go ahead.
Representative Carpenter.
Thank you, Mr. Chairman. So during that interim, we heard testimony from the anesthesiologist and that frequently they drive, for instance, to Dodge City. And if they go out there with, a couple of patients and they can't serve that patient and they're not paid, they're just out that entire trip, which is, they take a lot of stuff to do this in the hospital setting. And so, they're just like, well, I guess we didn't get paid today.
And it's your question, Representative Morpeza?
Yes, thank you.
Okay, committee, any other questions? Megan, I do have a question, and I'm also looking at Representative Carpenter and Ballard just for what's next for these interim committees. So there's conclusions and recommendations that we have received. Some of these could be fixed statutorily. There's a lot of different ways. So just off the top of your head, will these go to Health and Human Services? So don't laugh. But I've been on interim committees the last couple of years, and I sometimes wonder what's the what next. So if you can't answer, Megan, I'm looking over to Representative Ballard and Representative Carpenter, if you would help to educate. Representative Carpenter.
So much like you just received the CanCare oversight one, the recommendations, we will take those draft language and bills potentially or provisos. And this is the same way. We will look at those items and see what we can do. One of the big things that we found was that, and you saw it in there, the 3,000, and I don't know, we don't have the fiscal note on it, but the hospitals now are or charging them, they're paying $1,700.
Yes.
And so they're losing $1,200, that's what they get charged. So to rent that room from a hospital. So that's a barrier to access. So we're just trying to knock down barriers to access for sedation dentistry.
Okay, so, and part of that, asking that question, maybe for some of the new members of the committee, so it's either budget proviso in here, or it could be statutory in another committee? Representative Ballard.
Well, yeah, it could be, but I'm looking at it. Okay, so if they want to increase, if I'm correct, the Medicaid rate of 3,087, so that at some point is going to have to propose to us that this is what KDHE is asking, or will they build it into their budget that increase will occur? And I'm not sure by looking at it, which it says it's your number 4, but I will agree it needs to increase because it is not covering the expense.
Thank you, Representative. Megan, did you have an answer for that?
Yes. Rate increases for Medicaid go through the KDHE budget. And in the past, when the committee has made recommendations to raise rates, they'll get a fiscal estimate from the agency to get an idea of how much it will cost. They'll recommend adding that money to the budget for Medicaid. And then that money will stay in there, and those rates that it is intended to address will be raised. So, for example, last session, the committee recommended that provider physician rates be raised. And that was an example of the money was added through this committee and then continued through the budget process. And in the appropriations bill, it included money to pay physicians at a higher rate.
That's helpful, thank you. Okay, committee, one more time. Any other questions? Okay, Megan, thank you. So back on our agenda, we have overview of the Kansas Department of Health and Environment. Is Janet here? Oh, Janet, please.
Am I? No, okay. Good afternoon, Representative Bueller and committee members and new committee members. Janet Stanek, Secretary for KDHE. Been in this role 3 years, but heading into my 4th session. So today I have 2 staff members with me that will help give an overview. We understand you wanted an overview of KDHE, is that correct? Yes, so KDHE is comprised of 3 divisions. Our mission is to protect and improve the health and environment of all Kansans. Our divisions are Public Health, and Deputy Secretary Ashley Goss is here. Medicaid, which is also known as the Division of Healthcare Finance, DHCF, which Deputy Secretary Christine Osterland is here, and we'll talk to that. And she's also the Medicaid Director for the state. We are the single state agency for that. And then environment, but you're not interested in that today, even though there's some overflow there. So high level of the overall goals that we work on for the whole agency, we consider our personnel our most precious asset. So we spend a lot of time on our efforts to recruit and retain staff to carry out the mission of the agency. And I'd say we're progressing very well there. We have to adhere to a ton of regulations, some of which you're hearing today related to the letter and other things. We operate to meet all the legal and the legislative and federal requirements, and we have a lot of watchdogs on us, so we have a lot of moving parts. We are really focused on partner engagement. You'll see many of our partners in the audience today. We really have a philosophy of engaging and including in the decisions we make for the programs because we don't feel like we can be successful without that. And also, we're really working on integration between the agency, the initiatives in public health, Medicaid, and also interagency, whether it be public health and agriculture, public health and KDADS mainly, and they're also our partner. So with that, I will be here for questions, but I'd like to turn it over to Deputy Secretary Goss to talk about the Division of Public Health, unless you have any questions for me right now.
Committee, any questions for Janet? Okay.
Okay, thank you.
Hey everybody, Ashley Goss, Deputy Secretary for KDHE. It's good to see all of you again. So I'm starting with the Division of Public Health. The next slide tells you what the mission of the Division of Public Health is. I won't read that to you, but it's the next slide. Following that is a list of all of our bureaus within the Division of Public Health. We have many. There's about 500 staff that make up all of these bureaus in order to carry out the work of the division. On the next pages, you'll see kind of an overview of each bureau. So Bureau of Community Health Systems, this will list some of the programs that are in it. We are updating a legislative book, actually, so you can have so you can see all the programs. Also, all of these are listed on our website. But our Bureau of Community Health Systems is where our local public health program lives that works directly with our local health departments across the state. It's also where our rural primary health care program is as well. One of those I'm sure you've probably heard of. And they provide funding across the state as well to safety nets and then federally qualified health centers. Bureau of Facilities and Licensing, that bureau is exactly as it sounds. That is a CMS required program. That program is responsible for going out and doing surveys pretty much for every type of health facility except for long-term care. KDADS does provide those surveys to long-term care facilities. So not only are we responsible for going to make sure that they're meeting all the CMS requirements to be a licensed facility, then we also go, if we get a complaint, that we have to go and investigate those as well. And then, of course, if we have a significant complaint and CMS deems it as a life safety issue, then those are considered immediate jeopardy complaints. It takes significant resources to do those. This is probably a program you'll hear about maybe during this session. It's significantly underfunded by CMS, but it's work that's required. You'll probably hear the same things from our sister agency, KDADS, as well. The Bureau of Epidemiology and Public Health Informatics, they are data hubs. They collect all the data that we receive in. A lot of the dashboards that you can see on our website is exactly where that data comes from. They're the ones that house all of our epidemiologists. We have epidemiologists that work across the division that are looking at statistics, data collected, different things. But they're the ones who clean it, look at it, interpret it, and ensure that it's correct and accurate before it's posted. Bureau of Health Promotion, I often refer to as the bureau that gets to do innovative things. They're all very innovative, but this bureau is responsible for thinking about the prevention side of health. So the topics aren't necessarily fun, but working to prevent them is something that is very significant. So that, like, we have our cancer section in there, suicide prevention is in there. We do a lot of work with community health workers, different programs like that are what is in that bureau. Next slide. Bureau of Disease Control and Prevention. This is where our immunization program lies. This is where our sexually transmitted infection program lies. And this is also where the tuberculosis program is as well. So this bureau is made up of staff who can help manage those types of things. They also can assist the local health departments or the local entities that may need assistance in providing contact tracing or disease investigation to help find, for example, with a sexually transmitted infection, to help find all of the partners and get them treated to stop the spread of disease. They're also very this is also where a Vaccine for Children's program lives. So they also work with the local hospitals if they have the birth dose hepatitis vaccine. They work with health departments, safety net clinics to establish the Vaccine for Providers Children program. That's the vaccine that's provided for children underserved or uninsured for free. The Bureau of Oral Health is small but mighty. We have 3 employees, one of which is our state dentist. Dr. Dana Brinkman is the one who heads that up. They partner throughout the state doing screenings and working with community partners to increase those as well. Bureau of Family Health is another one of our very large bureaus. It's responsible for all things women's health, basically birth to death is how I like to describe it. So they're interacting not only with pregnant persons, but also then once that the baby has been delivered, home visiting, maternal child health, all things birth to death in that program. There's too many to mention, honestly. We can talk in depth if you have questions. Also in that program, we have the Kansas WIC program, so that's the Women, Infants, and Children's program. The counties are served by Women, Infants, and Children program. It's a USDA program. We administer it, 100% reimbursable from the USDA. All of those are offered in every county. Some counties serve multiple counties, but every county is served. In addition to that program, we have the child care licensing program in that bureau as well. For those of you that were here the last 2 years, I know that you probably heard all kinds of information about the child care program and the licensing program. That's also the same program that we rewrote all of the regulations in and brought them up to date, got them published and out the door. And finally, our Kansas Health and Environmental Lab. If you have not seen it, it's very hard to miss. It's right across the street from the docking building. We are currently starting to move into that building. We would invite any of you for a tour once we're up and going. Currently, we're operating out of 2 facilities. The old lab is at Forbes Field. If you've never toured that one, you might want to go there first and then see the new one. It's interesting. But the staff is moving into it, and we are in the process of moving over all of our testing equipment. Of course, when we move testing equipment, vendors have to come and certify all the equipment before we can actually use it. So we are kind of doing dual labs right now. So we keep one machine up and going at the old lab while we're getting the other one calibrated and certified at the new lab. The one thing that we're waiting on before it's completely finished and operational to move everything there is our generator. The generator was ordered over a year ago. We still don't have it. It should be here towards the end of the month. So our BSL-3 lab, which is the lab that can analyze stuff that we don't like, such as anthrax, unknown substances, things like that, cannot be certified or moved until the generator is in place, and that is a CDC requirement. All right. Next slide is our accomplishments. There's far more than what is on this page. One of the things you may have seen a press release on, I believe today, came out that we were reaccredited by the Public Health Accreditation Board this year. We were just recently notified of that, I should say, at the end of last year. That is a very big undertaking to remain accredited. We were accredited 5 years ago, and then we go through the cycle every 5 years to become reaccredited, and we were able to achieve that every 3 years for reaccreditation. Very proud of our staff. Lots of hours put into that and work. And you may be hearing, we're partnering with KHA on some of this, but the misuse of antibiotics resistance and effectiveness. So we were able to establish a program for prescribing to healthcare providers to provide more education around the overprescribing of antibiotics. On the KHA side, we're working with them to work on infection prevention, and so we try and do things together and educating our providers around the state. Our Kansas Home Visiting Universal Home Visiting and Maternal Infant Children Childhood Home Visiting Program, that's a mouthful, increased by 31%. So we were able to serve 31% more families in that program. I already mentioned childcare licensing. And then we have, and we still have, mobilized staff and resources to address a tuberculosis outbreak in conjunction with CDC. CDC is on the ground with us the majority of the time in Wyandotte County to work on this outbreak. We are starting to see the numbers finally kind of take a turn and come back down and getting people off treatment. So that's a positive. And then K-Hel, as I already mentioned to you, thank you to the Department of Administration, the Building Committee, in giving the funding for that new lab to be established. Super excited. The staff is ecstatic to move in. So goals on the next slide, of course, getting the TB outbreak under control and hopefully to an end. Working collaboratively, as the Secretary said, with Medicaid on the newly awarded TMAW grant. I won't steal Christine's thunder. I'll let her talk to you all about that grant that we were just given. And of course, implement a smooth lab transition. Our legislative initiatives that you'll hear about later in session would be the update, the newborn screening cap to allow for program growth and expansion. Representative Carpenter is very familiar with that. He's helped us on a regular basis to ensure that we have that proviso. Increase our state formula funding for local health departments. So the state formula funding was increased. It's getting the words in the statute to align for the health department so that it is set versus having to add a proviso in every year, which is what you guys have been doing for the last couple of years for us. And then establishing, this is new, a regulation and licensing for nuclear fusion systems, including a new fee structure. So we currently don't have this in Kansas, but it's coming, is what we have been told. So our radiation program is being very forward-thinking and at least wants to get this type of energy established within our current regulations, so that when they come to Kansas, assuming they do, they're working in other states right now, that we already have that in place and we don't have to scramble to write a regulation, to set a fee, and to establish what they're required to do if they're going to operate in our state. And I think that's it. Do you guys have any questions for me?
Representative Wilcott.
Thank you, Mr. Chair. On page 12, back a slide or two, it says KDHE was reaccredited for public health. Does that mean we lost accreditation, or it's a renewal of accreditation?
It's a renewal of accreditation. And that includes public health and some of our Medicaid division. It never includes environment, which is unfortunate because we work very closely with our environmental division as well. So it's reaccredited. We don't ever want to lose it. It's a ton of work to get there. Yep, sure.
Committee, any other questions? Okay, thank you. So is Christine?
Yep, she's next.
She's the finisher. Christine, welcome to committee.
Thank you, Chairman and members of the committee. I'm Christine Osterlin, Deputy Secretary for Agency Integration and the State Medicaid Director. So in the Division of Healthcare Finance, unlike public health, we basically support one mission, and that's to run and operate the Medicaid program and children's health insurance program for the state of Kansas. So my presentation is going to be a little bit about an overview of Medicaid, just because, again, I know you will be dealing with a lot of funding aspects of Medicaid, so you have a base understanding of the program. And as you've heard, there's lots of federal requirements that come with Medicaid. So in Kansas, the Medicaid program is actually split between KDHE and KDADS, our sister agency. From the federal government perspective, they require that one agency is deemed the single state Medicaid agency. So as the letter that was referenced earlier, you will see it's addressed to me. The reason for that is KDHE is the single state Medicaid agency. So anytime CMS is going to officially communicate with Kansas, they're going to send it to me. I'll then obviously involve our KDADS partners. So how it's kind of split in the state is KDADS, they oversee the home and community-based waivers. They oversee the behavioral health components of Medicaid as well as the long-term care population. KDHE, we have responsibility for all other populations as well as our managed care contracts, which includes oversight and compliance of our 3 managed care organizations. Next slide. So Medicaid and CHIP, it is a partnership between the state and federal government. The state does have some flexibilities in how it designs its Medicaid and CHIP program, but all of those designs must meet federal requirements. We can add populations and services upon federal approval. The Centers for Medicare and Medicaid Services, they oversee the program. And again, we are required to comply with all federal rules and requirements. And that includes CMS approval for any programmatic, policy, or funding level changes. So really everything that is done at the Kansas level, we must seek federal approval in order to receive federal funding. How that funding comes from the federal government for our Medicaid population, we receive about 62% of the funding comes from the federal government. For our CHIP program, it's about 70% that the federal government pays. And then the federal government also pays for personnel, our contractual services, so like for our claims payment system, our eligibility system, and our IT cost, and those matches range between 50% all the way up to 90%. So the federal government does pay for a substantial portion of our program. Next slide, this is just a look at our Medicaid enrollment between the two programs, Medicaid and CHIP. We serve 440,812 folks as of the end of October. I laid out the 3 largest categories of enrollment below that, with the bulk being in the Medicaid program, almost 361,000. We have about 61,000 in CHIP, and then we have about 16,000 in what's called M-CHIP, and that's our young children up to age 5. Who is eligible for Medicaid? So one thing to know about Medicaid, it is an entitlement program, which means that everyone that meets eligibility rules has the right to enroll in Medicaid coverage. We cannot cap those entitlement programs. In order to be eligible for Medicaid in Kansas, a person must be in a covered group. They must be a child, a caretaker of a child, pregnant, disabled, or elderly. They must meet one of those criteria. Then they must meet technical requirements around citizenship, residency. There's a few other items in there. And then they must meet financial requirements or thresholds. These thresholds vary by category. HCBS has higher thresholds than, for instance, Medicaid for children. Caretakers have the lowest thresholds. So again, it will vary by program. But essentially what it means is someone must be a child and meet the financial requirements. They must be a caretaker, and so it's like a 2-step threshold in order to be eligible for Medicaid. One thing I did want to point out is DHCF, or Medicaid, we process eligibility applications for Medicaid and the CHIP programs. SNAP and TANF and the other public assistance programs, those eligibility applications are processed by the Department of Children and Families. So families do have to apply with 2 different agencies if they're seeking multiple public assistance. A little bit about the services that Medicaid covers. The federal government requires states to cover what they refer to as mandatory services, but allows states the option of covering other services. If we want to receive federal funding, we must cover the mandatory services. The optional services, we will get federal match for those if we get federal approval before implementation. The one nuance in all of this, because, Medicaid, we'd hate for it to be straightforward, is for children. There is a provision in Medicaid called Early and Periodic Screening, Diagnostic, and Treatment, or referred to as EPSDT. That requirement is that a child is eligible for any medically necessary service that will treat or ameliorate a condition. So that goes way beyond the traditional mandatory and optional services. So it's a little bit of nuance for children that they kind of fall outside of what we call mandatory and optional. The other thing that I'll point out about mandatory and optional services is because Medicaid was actually initiated in 1965, when our healthcare delivery system looked very different, mandatory and optional services do not fall along the lines you would think. And I gave some examples. So mandatory services will include hospital, inpatient and outpatient, physician services, laboratory, x-rays, transportation. There's quite a few more on the list. But optional services include prescribed drugs. In our current day and age, prescribed drugs seems kind of silly to be an optional service, but that is actually under the Medicaid program. Hospice is optional, podiatry, durable medical equipment. So again, while there's, again, some of these services are optional, you would look at them and think, well, that doesn't seem like a really optional program to me. Kansas is a managed care state, so roughly 95% of both our Medicaid population is enrolled in managed care, and 100% of our CHIP population is in managed care. Some examples of our Medicaid population that would not be in managed care would be PACE. That's an all-inclusive care for the elderly program. We have a tuberculosis program, Medicad program, which is 100% state funded. So they're very small programs. And those are really the only ones that are excluded from managed care. What that means is that Medicaid will pay those providers for services provided. Managed care, I think as you all are aware, we pay the managed care plan a per member per month fee capitation rate for all the services provided. Currently, our 3 contracted MCOs are Healthy Blue, Sunflower Health Plan, and United Healthcare. So that's just a high-level overview of Medicaid and what we do. Some major projects that Kansas Medicaid undertook in 2024, and Ashley alluded to this. We've had a lot of focus on prenatal care and maternal child health outcomes, which included we were awarded a $17 million grant over a 10-year period focusing on maternal and infant health outcomes. With the kind of sub to that would be a lot of focus in our rural communities, also some focus on telemedicine and some other alternatives. But this is a big win for the state of Kansas. We have a lot of work to do in our maternal and infant health area. So we were very excited to be awarded that grant. We were just notified right before the holiday season, so we are just getting it off the ground. It was a great end of the year present for us. So much more to come during the session on what this grant is and all the activities that we'll undertake, but a lot of our stakeholders were very instrumental in us getting this grant, as well as our public health division, a very collaborative effort to secure this funding for Kansas. We implemented the CanCare 3.0 contracts. These contracts included hundreds of changes from what we called CanCare 2.0 that was operational up until December 31st. We focused a lot on member outcomes and provider experience, in addition to enhanced monitoring and oversight from KDHE. We completed unwinding from the COVID-19 public health emergency, which included Kansas. We were recognized in November with a national award out in Washington, D.C. for our efforts in unwinding. In addition to the maternal and infant health grant that we were awarded, we were also awarded a school-based services grant. It's a $2 million grant, but this will expand services to Medicaid children in the school setting and will allow Kansas hopefully to also include CHIP children in school-based services. We've completed our first rate study in over 6 years. We're starting to post those results online, and we're also meeting with stakeholders around the results of that rate study. And we created a data and analytics bureau. I will say Medicaid was behind the curve when it came to data and analytics and being able to provide that data not only externally, but how to use it internally to oversee and monitor our MCOs. So we have a bureau now created that will allow us to enhance those efforts. Next page, I think this might be my last page, is what our goals are for this current year. We want to fully implement our CanCare 3.0 contracts. Today, we are on day 14 of Go Live. So far, so good. We know there'll be some bumps in the road, but going well so far. But again, there's still more work to do as the MCOs completely roll out all these changes and we make sure it's operating as we anticipated. We are initiating year 1 of the TMAW grant activities. And we are going to now start to undertake phase 2 and phase 3 of the rate study. We'll be happy to come back and talk more about this. One of the things that we learned, we added an additional phase to the rate study. So those of you on Bethel knew there was going to be a phase 2, but we've added a phase. What we've learned in the rate study is that in many instances, our managed care organizations are already paying above the Medicaid fee schedule. So if you increase the Medicaid fee schedule, the MCO may already be paying above that, which means there's really little to no impact to the provider directly. All we're doing is closing the gap between the fee schedule, which is what we pay the MCOs, and what they're already paying the provider. So another challenge for us yet to unravel and learn how to solve. Our goal in 2025 is to complete research and recommend a revised graduate medical education program. You heard about that in one of the interim committee reports of the need to revise our GME program. And again, with our data bureau implementing public-facing dashboards on MCO performance and other key Medicaid data that up until this point has not been publicly available. And with that, that is a look at DHCF.
Thank you. Christina, are there any questions? Oh, yes, please, Representative Ballard.
Thank you. I don't have any questions, but I do want to say congratulations. I mean, to find out before the holidays,
yes,
it's nice. And you said $17 million
yes,
grant over what period?
10 years.
Over a 10-year period of time, and there were multiple submitters.
Yes, yes. I think there were 17 awards. 17 states won awards. It was 15 or 17. Yeah.
That is really nice. And then there was the $2 million for the school base.
Yes.
Often, you know, we tell people we fund through the state, yes. But these grants are things that actually within the department you initiated in order to get that additional money in order to do it. And that takes a lot of work. I mean, I submit grants. I know how difficult it is.
Yes.
But I do want to say to those people who were involved, we really appreciate that. And that saves the state money because they give us money, but then there's another way that you can get money. So
exactly. Thank you. And I will pass that along. Thank you. It is a lot of work.
Representative Steens.
Yes, thank you for being here, and thank you, Mr. Chair. So I have a question about the MCOs. Do the clients that you have on Medicaid, do they get to pick the MCO that they have? Okay, and how does that just, as it decided between like, when we were talking about the children versus like maybe those that are elderly that are on your plans, is there one over another between the UHC or who was it else? You had Sunflower, UHC, and Health Blue. So how does that work? Because they used to have, was Aetna here before? Is that correct?
Yes.
Okay. So, because I heard Aetna was really good about paying some of these things. I'm just curious, like, how did they decide that Aetna was no longer going to be one of the MCOs?
So that was through a competitive procurement process by state law. We have to re-procure our MCO contracts every 5 years. Yep. And so that was through a request for proposal process that we did throughout late 2023 into spring of 2024 was the whole procurement process, which then we selected Healthy Blue, Sunflower, and United. And so on December 31st, Aetna stopped being a Medicaid MCO when Healthy Blue started. But how members pick their plan, really the differences between the plans are in provider network. There is a lot of similarities. If you look at their numbers in their provider networks, they're pretty close. So there is a lot of similarities, but there are some differences. So again, I may have a particular provider I want to see, and they might participate with one or two or maybe all three. Each of the plans have value-added benefits, so those are benefits not covered by Medicaid that they choose to cover. They can be like over-the-counter medications they might pay for. You know, they might provide gift cards or memberships at gyms or nutrition or a variety of things, and those do vary by each of the plans. So a lot of times members will look at those items and see which one, you know, because again, if I have a small child, if you're providing diapers through your value-added benefit, that might be a deciding factor, where if I'm elderly, like you said, that may not be, you know, that may not entice me to choose that plan. So they do have a time to choose. If they don't choose, we will auto-assign them. We'll randomly pick the plan for them, but then we give them 90 days if they don't like that plan to make another choice.
All right, committee, any more questions? Okay, thank you. Representative Carpenter.
Yeah, so EBTSD.
Your favorite term.
Yeah, exactly. I can't believe I actually said it. Maybe I got turned around.
I believe you said it.
Yes, you did.
Said it right, even, I meant, yeah. So our balance last year, we started with 50 million. What's the usage been on that? You know, we didn't have a clue what we were going to need for that, so last year.
And I can run some updated numbers for you and see where we ended. It will be probably, you know, because claims come in arrears, so it won't be a complete picture of calendar year 2024, but we'll see where we are. It'll probably be, I would guess, probably through the end of September. I would assume most of those claims are in, but we'll run an updated number.
Great.
Yep.
That's a good question.
Committee, any more questions? Okay, thank you so much, and I do want to apologize. I did not use Secretary Gannick's title, so I apologize. So anyway, before we adjourn for today for the committee, we will have committee rules coming out by the end of this week, maybe early next week. So just kind of stand by and use what we did in 2024, and if you weren't here, just act nice. General guidance.
Nice.
Yeah. Attention is to be a paperless committee, so bring your laptops, especially when we get into if you look at the schedule for the month, we have agency overviews and we'll have budget hearings, be a lot of documents. Francie is reiterating this point that we're going to be saving. It'll be on the S drive. Yep. So if you want your Yep. 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 Just get comfortable with the S drive. And I guess what I would say is there's a lot of work to do between now and February the 13th, just to keep the whole budget and the appropriations process going. I see Representative Ballard shaking her head. I was actually watching a video of her in this very setting a couple of years ago, so I know what we're in for, having not done this. But it will require us to work together, to be collaborative, be patient. This isn't always the most energetic and fun thing to do, but it's important work for the state. So I appreciate your time, and we will see you on Thursday is the next meeting. So we're adjourned.